Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners to the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks.
Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce Daniel Nowak. Daniel, thanks for being on the show today.
Thanks, Doc. Thanks for having me. Really excited to be on your show.
Now, Daniel, you work with Rowe Dental Laboratory, and you're in charge of the Chrome Full Arch Guided System. Why don't you tell me a little bit about yourself and some of your history, how you got into dental, and then we'll go into a little bit about Rowe Dental Laboratory.
Okay, great. So I'm originally from Poland. My parents immigrated to Canada when I was 8 years old. Ended up, getting my formal education at the University of Saskatchewan in Saskatoon, Canada. And really my first job out of university was working for an implant company called Noble Biocare. And I got introduced, it was kind of fluky how I got introduced to Noble Biocare, but I ended up taking the position, and the rest is history. And while I worked for Noble Biocare, at that point in time, guided surgery was just making it the way to forefront of dentistry, but as well as a protocol that was developed by Paulo Malo, as we know today, the O&4 protocol, where, we can, at that point in time, what we were doing is we're taking the teeth out and immediately loading prosthetics, where we took a denture and converted it into a screwed down bridge at the time of surgery. So that was many, many years ago. And at that point in time, that was cutting edge technology. But at that point in time, with the conventional, O&4 protocol, some of these cases ended up, taking 7 or 8 hours, and the conversion itself can be as long as 5 hours. So, trial and tribulation, I learned a lot being with Noble Biocare. Then ended up working for Straumann for a little while, and then ended up at Rowe Dental Lab. And my position at Rowe is that I'm the national sales manager. And we're very unique in the regards that we're also a medical device manufacturer, and we've got a patented metal stackable system for full mouth reconstruction where, with proper treatment planning and a little bit of experience, you can now do an entire case in as quickly as just over an hour.
Yeah, that's amazing that you got right into Noble Biocare at kind of a premium time when all the full arch and the guided systems were all coming to kind of fruition at once, and the technology was all merging with, the forethought of the all-on-4 process. What did you do with Straumann while you were there?
It was quite interesting. I ended up leaving Nobel and ended up with the company GuidedSMILE, which is what we know as the Chrome system today. And at that point in time, I ended up flying out to meet with Marco Gadola, the CEO of Straumann, and they were looking to buy the system. And at that point in time, it just made sense that I would transition from GuidedSMILE to Straumann and kind of facilitate perhaps the sale of this technology. And things didn't work out. Ended up leaving Straumann and going back to GuidedSMILE and Rowe Dental Lab.
Excellent. So with Rowe Dental Lab, you said you're a national sales representative. Now you're actually based out of San Diego, California. Is that right?
Yeah. I'm the national sales manager, and I work across the entire United States and Mexico. So for me, even though our main milling facility is in Cleveland, just outside of Cleveland, Ohio, in Independence, I'm based out of San Diego. But most of the time, I'm traveling almost every week out of the month. So as long as I'm near an airport, I can get my job done.
Now, are you in San Diego because of a lot of the hands-on training that Rowe and Chrome do is in Mexico there, or does that just happen to be where you were living and it worked out for you?
Yeah, no, just, my wife is from Illinois, and she kind of escaped the cold and moved to San Diego, and that's just been our home base. And, I was fortunate enough to have this opportunity to work for Rowe. and be able to live off-site from where our production site is located.
Excellent. Well, let's go into Rowe Dental Lab a little bit. Just kind of give me a brief understanding of what Rowe Dental Laboratory is and how the Chrome system works within there.
Right. So, Rowe Dental Lab has been around since, I believe, 1928. So we're going close to 80 years now. It's a family-based business. And we're a full-service laboratory that also has this, in a way, medical device division where we make these stackable systems. And a lot of people look to us almost in a way as we have a lot of patented products that we have under our roof, and we really specialize in these digital workflows. So, coming from the implant side and working with multiple labs, in my career, in both the United States and North America. The one really neat thing about Rowe is that really the organization is at the forefront of digital workflows. And I haven't been exposed to any of the other laboratories throughout the United States that are doing what we're doing right now at Rowe. So it's very exciting to be part of this organization.
Yeah. So let's go through the Chrome full arch guided stability process. Now, for people that don't know what that is, it's basically a way to do an all-on-4, an all-on-6, basically an all-on-X conversion through, like you said, a digital workflow. So you take pictures, you take comb beams, you're taking models, however you're getting it, you're merging all that together, and you're figuring out a way to do a fully guided fixed arch solution day of surgery and transition that to a complete process. So kind of work through, people. Tell me what it is. Tell me what goes on with that and why this is such a big deal. I mean, I know this is a big deal, but kind of tell people why this is awesome as it is.
Well, so if I may, I'm just going to back up a little bit and kind of go through this whole sort of renaissance of guided surgery. So,
sure.
When Nobel came out with what we call as Nobel Guide, many years ago, everybody got really excited, right? Because they're like, well, we're going to be able to do guided surgery on these patients, and we're going to be able to have the teeth pre-made, and they're just going to screw in. And it's going to be a beautiful process. Well, what ended up happening is that everybody started realizing that the majority of these cases are not patients that are edentulous. The majority of these cases are indications where the patients have existing teeth. So what ended up happening is guided surgery didn't work for these patients at that point in time because, even today, if you look at the guided systems on the market, the workflow is this. If you wanted to do guided surgery, you would have to extract the teeth first. You would have to do the bone reduction, and you would have to let the patient heal up. Then you would go back and take another CT scan, and then you could possibly plan your surgery with a guide, guided surgery, and then you'd have to somehow figure out on how to do the prosthetic over top. So, and because, the majority of these cases are patients with existing teeth that don't want to go in a denture. And what's happened is Clear Choice has really made an entire industry of this. I think Clear Choice does something like over 8,000 arches a year, and I think they're placing 36 to 40,000 implants a year. And they found out this niche for patients that don't want to go in a denture. And so what's been happening is, you still have sort of the old regime and clinicians that want to do stuff that's delayed, but then you got patients that are really savvy and they're doing their research on the internet and things like that, and they're finding out that there's no reason why they need to go in a denture for 6 months and not be able to function, but they can actually walk out with teeth the same day. So this whole protocol or this whole modality, it just appears to be very much patient driven. So kind of getting back to this whole thing of guided surgery, is that with this Chrome stackable system, we figured out a way where we can do fully guided protocol all in one appointment with existing dentition. So what Chrome really is, it's a stackable system that allows us to have guided tooth extraction, guided bone reduction, guided implant placement, guided implant connection timing, guided multi-abutment placement and timing, and then guided prosthetics all in one protocol. So that's very unique. And because, everything is pre-planned, when we do up the treatment plan for one of these cases, it's almost like you're doing the surgery virtually prior to the patient even arriving. So you know exactly what's going to happen. You're going to know exactly, you know, bone qualities, how the prosthetics are going to work. You almost do a dry run virtually through it. That way, once we put together the treatment plan and the stackable system is built, it's just a really smooth process to actually do the surgery at the time when the patient arrives at the clinic.
Yeah, I that's amazing. I've done a bunch of no-bell guided surgeries, but I had to do, like you said, I had to pull teeth, wait 3 months, take a new guide, place the implants, wait 3 months, then make the prosthetics. And I think nobody's wanting to do that anymore. Let's go right to the finished product. And so the fact that your system goes from A to Z all in one process, and it makes it more predictable, and it takes it quicker, and there's less patient surgeries. I mean, it saves everybody time and money and effort that just doesn't need to be wasted. So it's really an incredible thing. So let's say someone's got a patient like this in their practice. Someone walks in and says, I've got these terrible teeth. They're broken off. They need extractions. I want to go straight to fixed. Walk somebody through that protocol. Is that what do we do now?
Yeah. So basically, there's a couple modalities how to treatment plan these cases. But what we like to do is we like to start off with a picture of the patient's entire face, and we can actually do smile simulations that we can deliver back to the clinic with the patient's face and their new smile. We can actually do a digital mock-up of what the smile is going to look like. So we usually begin with a smile simulation, show the patient. And it also, the great thing about the simulations is that it also helps with case acceptance. A picture's worth 1,000 words. And, and one thing, if I could just kind of touch on patient mentality, is that, a lot of these patients that may show up at your clinic, have, maybe failing dentitions, they got perio. And, a lot of them, the reason why they don't go to the dentist regularly and they don't get cleanings is because they had, some kind of a horrible experience when they were a child with their dentist, right? And now they're scared of dentistry. And sometimes when these patients show up, they want to have the protocol done or the procedure done, but they're actually there to find any reason not to do it. And what ends up happening is a lot of clinicians, when they start talking about, plastic teeth and surgery and, all the stuff that goes along with these protocols, sometimes these patients just get scared and they run away. So, we like to start off with the smile simulations, and we want to show the patient what their smile is going to look like, because that's really what they're there for. You could probably agree that a lot of these patients don't really care about implants, hardware, parts and pieces. They're there because they want a beautiful smile. So how we like to bring in our process is to basically, you take a full face photo of the patient, you send it to us, and for $59, we're going to send you back a lifelike rendition of what that patient's going to look like with their new smile. And the power of the simulations is that, a picture's worth 1,000 words, but at the same time, sometimes we'll do the simulations and the patient will disappear for 4 or 5 weeks. And all of a sudden they show up out of nowhere. And we're like, well, what happened to you? Where did you go? And they're like, look, I kept looking at that picture over and over again, and then finally decided that I need to do this. So there's a lot of power in a simulation. So that's stage one in case acceptance that we like to do. Stage two in case acceptance is that if you do the simulation and the patient's still on the fence, what we can actually do is we call it a bite proof, but we can create a smile that clips over top of their existing failing dentition, and they can test drive it for 3 or 4 days and see what they're actually going to look like with their new smile, how it's going to feel, and they can go in public and experience maybe some of the things that they were hesitant to do so is because they didn't have a beautiful smile. So moving forward, so once we get patient acceptance, patient wants to move forward, what do we need for records? Well, we basically have two modalities, and I'm going to cover first how we deal with a patient with existing dentition. So if the patient has an existing dentition, all we need for records is we need some clinical photos. We need a straight-on shot with the patient in occlusion, and then we need 2 other photos where the patient is occluding on the posterior right quadrant and the posterior left quadrant. So once we have the pictures, the next step in this process will be to take a PVS impression and a bite registration. However, if the office is digital, we can actually do a digital intraoral scan with a bite simulation. And then the only other thing we need after that is just a CT scan of the patient biting on a cotton roll. So that's your straightforward case. If we can get a good bite, and the patient's bite is not collapsed, and that's what we would do for records to move forward. Now, if, for example, the patient had a collapsed bite, and the bite was really messed up, maybe they only got like 2 or 3 teeth, and we can't really get a bite. At that point in time, what we would do is we would make a scan appliance. So what the clinician would do is we would almost begin the whole workup as if you were going to make a partial or a denture. We would have some white wax bite blocks. They would bite in on that. And then from that, we would make a scan appliance. And what a scan appliance basically is that, just almost think of it, if the patient's missing a bunch of teeth, it's almost like we're making a partial, and that partial is going to snap in, it's going to stabilize the bite. And then what we're going to do is we're going to attach gutta-perca markers to it. And the protocol would be for the CT scan is the patient would be scanned with that appliance in the mouth, biting on cotton rolls, and then we would just scan the appliance by itself. And that's how we would create the virtual bite. And that leads us into our third modality, which is, well, how do we deal with a patient that is edentulous? Well, the way we deal with a patient that's edentulous is if they have a good fitting denture, then what we would do is we would put little gutta-perca marker stickers on the denture. We would put 3 on the facial, 3 on the lingual. And again, we would scan this in the patient's mouth, and then we would scan the denture outside the patient's mouth. So in essence, what we're doing is if it's a good fitting denture, we're turning into a scan appliance. Now, if the clinician wasn't happy with the denture, the patient wasn't happy with the aesthetics of the denture, it wasn't a good fitting denture, then at that point in time, we would again make a scan appliance, which will be almost like a denture, but it's going to be milled out of a clear material with the proper tooth shape and a proper bite. And again, we would scan that in the patient's mouth, and then we would scan that outside the patient's mouth. And those are really all the records that we need.
Yeah, so it's nothing outside of most things that practices doing full arch dentistry and guided dentistry that they wouldn't already be getting anyway. I guess that where the magic happens is how you guys are putting it together and what you're doing with it. So let's say everyone gets those records, and that SMILE simulation really helps. They get them nailed down for treatment and say, okay, we want to move forward with this. We send all this information off to you and kind of tell me what happens next. Where does that go? And there's probably a process where you and the doctor kind of work through it, kind of guide the surgery and start producing some of these pieces, right?
Right. So, so basically what happens is once you have all the records, clinicians can actually reach out to me. And what I will do is I will create an upload portal for them. And I can log into their computer and help them upload the cases. But we do everything digitally and web-based. So what we would do at the time when you have your records, we would just create a portal for you. You would put in your patient's name. We're going to fill out a digital RX, so we know what implant brand you're placing, where do you generally want those implants to be, and a couple other pieces of information like shade and whether you want to change the vertical dimension or not. We do that all digitally. So once we fill out this digital RX, the next step is we will upload the information through our web portal in the patient's digital RX section, right? So you'll have the patient's name, the parameters of the case, and then there's going to be a little button there that says add documents, and that's how we would upload the pictures, and that's how we would upload the DICOM files for the CT scan, and any other information that the doctor would want to include. So once we do that, we fill everything out, we upload what we need to upload. From there, we print out a digital RX, and then from our website, you just click on the UPS label, and we'll generate a UPS label for you. And then you just take the RX and the label, throw your models in the box if we're just taking impressions or models, and then you ship that out to us. And once we get all the information, what happens in the first 3 days, we build the digital bite. So once we get all the information, we're going to digitize the PBS impressions if that's what the clinicians have sent over. We're going to build the virtual bite. Once we build the virtual bite, we're going to start creating our stack. So we're figuring out where the bone reduction is, where everything kind of needs to be positioned and put together. Once that happens and we build the virtual bite, we then invite the clinician to an online meeting, and the clinician will sit with one of our biomedical engineers, and we will plan the implants. And once the implants are planned, there's going to be a plan that's generated. Once the clinician approves the plan, which is typically done at that treatment planning session, it takes us 10 lab days to produce this device before it arrives at the clinic.
Okay, and you're talking about this device. This device is actually a lot of pieces. So let's kind of go through what it is. So everything goes smooth. I get the device back in the chair. I've got to get my patient numb. Let's say they've got a handful of broken down teeth. What are we looking at here? How does this go? I know it's better to see this virtually, but kind of walk someone through what this process is going to look like, because your device is a lot different than other devices. It's got a lot of moving parts, and all those parts have specific names to them.
Yeah. So, actually, compared to some other systems on the marketplace, this is probably the simplest one to use, and this is how it works. So, patient's going to come in. First things first is we're going to create. We're going to flap the tissue away from the teeth. Once we flap the tissue away from the teeth, and we do a very, very conservative flap, we're going to reflect the tissue, and then what happens is our foundation guide or our pin guide is going to go over top of the existing dentition, and there's a polymer piece that basically fits over top of the teeth and starts the position of where the stack needs to be. So once this first piece goes over top of the teeth, what we then do is we drill it and we pin it. Once we drill it and pin it and stabilize it in the patient's bone, we have a Swiss lock system on this chrome device that is basically a series of little tiny plungers. We open up the plungers, and what ends up happening is this polymer piece will actually come off of the teeth, and it turns into the bone reduction guide. So at this point, what we would do, we would extract the teeth, and we would reduce the bone flat with this base plate. Once the bone is reduced flat with a base plate, then we have our implant guide is going to clip into that base plate that stays in the patient's mouth through the entire procedure. So once this osteotomy guide clips in, at that point in time, the clinician would go through the drilling protocol and place the implants. Now, the very unique thing about this osteotomy guide that it's not your conventional osteotomy, not your conventional implant guide for guided surgery. And what I mean by that is typically when you have guides, you basically have a polymer piece over top that encapsulates everything, and then you have some kind of a master cylinder inside the guide that would guide your drills. Our system is different, where the rings themselves are out of metal, and they float above the patient's jaw. So you can actually irrigate through our guides, as well as you can actually see what's going on below it. So it's a very, very unique design, and I almost call it like a floating ring system. Now, the osteotomy guide in our system is going to, guide your drills, guide your implants, but we also have built into the master cylinder the timing of where the implant head needs to stop. So with conventional implants, you'll typically have, six flat sides on the implant connection. And what we need to do is when we're placing our implants, we need to time exactly where that one of those flat sides are in a particular position. And we have that actually built into the guide. So if we can time the position of the implant, we already have predetermined exactly where the multi-end abutment needs to go. And if we put the multi-end abutment in the correct position according to the plan that we did up virtually, all our prosthetics are going to line up. And that's going to lead to, an 18-minute conversion versus, taking a denture and trying to convert it into a small screw-down bridge. So after we place our implants and we timed our implants, the next component that's going to clip in, it's a plastic prosthetic delivery guide. And the prosthetic delivery guide is just going to snap in, and it's going to show us exactly the right position for the multi-end abutment. And how we time everything, it's all based on the lingual set screw on the multi-end abutment. So a conventional multi-end abutment, basically has two things going on it. You've got your prosthetic screw access, and then you have your lingual set screw, which actually screws down this angle correction abutment into the implant head. So what we do is when we put our prosthetic delivery guide over top, we have tiny little notches in the prosthetic guide that show the clinician exactly where to line up that abutment screw. And if we can line up the abutment screw in the right indication, what ends up happening is the prosthetic draw is going to line up perfectly with the prosthetic. Now, once our multi-end abutments are in, the next step is that we're going to introduce our temporary cylinders. We're going to put our temporary cylinders through the prosthetic delivery guide, And then we're going to take our teeth, and the teeth are basically going to line up over top of the prosthetic delivery guide. And there's basically 2 pillars on this prosthetic delivery guide that correspond with the prosthetic. And once you kind of clip everything in and the temporary cylinders are coming through the prosthetic, your restoration is going to be held in the proper vertical, proper midline, and proper occlusion. And then from there, basically, you're just going to pick up the temp cylinders in the mouth. Once the temp cylinders are picked up, you're going to unscrew everything. And we're just going to backfill some of the voids during the pickup process. And really, 18 minutes later, this whole conversion is done, and you're screwing the prosthetic back in, and the case is finished.
Yeah, that's amazing. I've done it all kinds of ways. And I know I've got a couple cases planned with your guide. I'm really looking forward to this process because it sounds like you've taken all the challenging and time-consuming parts out of this and made it so much more streamlined and so much easier to follow that it just takes all the headaches out of it.
Well, and it actually gets even better. so
keep going. Keep going.
Let's talk about So hey, the case is finished, right? Now the patient's ready to go to the final restoration. So, typically in a conventional workflow, to go to the final restoration, you're looking at about 5 to 7 appointments, right? You got to basically start what we call from ground zero. Well, with our digital workflow, we just released another product that we called the iJig. And the way that the iJig works is that for you to go to the final restoration, you're just going to take the temporary out of the patient's mouth when it's time to go to the final. And you have a couple different ways that we can digitize this. One is that you can take the temporary off, and if you have an intraoral scanner, you just take the temporary, you scan it outside the mouth. You scan the occlusal, and you scan the intaglio. And from that, your next appointment is going to be what we call an iJig, which is going to be a section 2 setup, which you're going to screw back into the patient's mouth, and you're going to take some Duralay, lute it together because it's going to come in sections, and then you're going to pick up the tissue with medium body impression material, and you're done. Your next appointment is screwing in the final. So the way that we can digitize the temp is we can digitize it with an intraoral scanner, or there's also a way where we can digitize it in a CT scanner. So one of the workflows is you just take the temporary off, throw it in a CT scanner, scan the thing, and send us the file. And from that, we would make the iJig. And the third way to get the iJig is if you don't have a CT scanner or you're not digital, you can actually take the temporary off and you would duplicate it in a duplicating flask like you would a denture. And then you send us out to us, and then again, we would send the iJig to you. So if I could just kind of summarize all this. So what does Chrome allow you to do? Well, if you're doing some of these cases for your very first time, the entire workflow from start to finish can be as long as 15 to 17 hours. And we're talking about the surgery, we're talking about the 3 to 5 hour conversion, we're talking about the 7 appointments having to go to the final. And with our system, you can actually go the entire workflow from start to finish. You can do in less than 4 hours, in a standardized, safe, predictable manner. And I got to tell you, even some clinicians that like to take their time when we're doing these cases, not everybody has to do it in 1 hour, but it's just a stress-free workflow. It's you're not second guessing anything. You're just utilizing the stackable system and stacking everything, and knowing exactly where your implants need to go, knowing exactly where you need to place all your components, and then having this prosthetic that's just going to clip in a proper occlusion, proper vertical, proper midline, and 18 minutes later that you're done.
Yeah, and I can tell you, I've had cases where I've spent 15 to 17 hours, start to finish. It's because things pop up that you didn't realize, and taking prosthetics on and off. I mean, there's a lot of time and material and headache that can be wasted in that process. So anything that can help streamline that A to Z is going to make it far better than trying to piecemeal all this stuff together on your own.
Right. And the other thing too is, we have this great stackable system that makes it safe and predictable. And we do this entire thing while cutting your lab bill in half.
Well, let's talk about the lab bill for a minute, because that's a huge component of these cases, because, keeping control of your overhead, having a lab bill that makes sense, and then being able to provide a solution to the patient that they can afford is a huge deal. I mean, some people are charging $30,000 per arch on these, $40,000 per arch. I try to keep mine closer to 20,000 an arch. So that means I have to really work with a company that keeps their lab under control. Tell me a little bit about the cost involved with some of this. I mean, what's a doctor looking at from start to finish, and are there ways to section some of the costs, or what's involved with all that?
Well, so our total package, which is the stackable system, all the treatment planning, the temporary, as well as the final restoration, all inclusive, is $5,999. And we have a global fee for the final restoration where you can have anything you want. So if you want a titanium bar with acrylic teeth, it's just one flat price. If you want a titanium bar with nano ceramic, it's just one flat price. If you want a Kevlar bar or a Trinia bar with nano ceramic wrapped around it, it's just all inclusive. It's the same price. And if you want a high-end Pretal cutback layered zirconia, within that package, it's all the same price. So you have basically, you've got 4 great restoration and 1 global fee. You can have anything you want. And it's a great value here in San Diego, for example, for a cutback layered zirconia. Here, the going rate is anywhere from $600 to $7,500 just for the cutback Pretal layered implant bridge. Where if you were to section our package off, we're doing this final for about $2,900. A high-end final for $2,900, and at the same time, saving about $3,500 to the chair time and making the whole process very simple and predictable. Yeah,
I can tell you, I've restored full arch in all of those ways that you've talked about, and I don't offer the acrylic anymore because I just don't like how they break and stain. And I know Pretal zirconia that can go for $5, $6, $7 lab bill just on the prosthetics, and the fact that you're getting the guide and all the parts for that is amazing in my eyes. Like you said, not to mention it cuts down your lab time, and all those things right there are just a real value for that fee.
Well, yeah, my favorite material, and this is kind of really coming onto the market, is this nano ceramic. And what is nano ceramic? Well, nano ceramic is a hybrid between composite acrylic with tiny nano ceramic particles in it. So it's sort of like the best of both worlds. And, if you really think about acrylic or a denture, it's a piece of plastic with glued in teeth is all it is, right? It's just a piece of plastic with glued in teeth. So, obviously then you have all those issues, right? Like you got glued in teeth. So yeah, a tooth's going to pop off here and there. And then on top of that, acrylic was really never meant to stay in the mouth 24 hours a day. It's a very porous material, and depending what the saliva content of the patient is, it can actually smell. So what I like about the nano ceramic is that it's monolithic. So it's beautiful compared to acrylic. It's much stronger, and it's not porous like acrylic, so it's very hygienic. And we offer basically 2 variations of the nano ceramic. So when we temporize, we actually temporize with a nano ceramic. So we've got 2 materials. We've got one that we use for the temporary process, and then we've got another material that we use for the final restoration. And the difference really is just the composition. When we go to the final nano ceramic, it just has a higher ceramic content in it. But it's very strong, but at the same time, it wears like natural teeth. And, the feedback we get from clinicians and patients is that, zirconia tends to be a little heavy, and especially if you do a double arch, it can clunk. With the nano ceramic and, for example, the Kevlar bar, it's extremely light. You get the same aesthetics of zirconia, but to the patient, it feels like real teeth.
Yeah, the Bruxer full arch bars, or the full arch, they're a little heavy, and they are kind of clunky with that, arch, Bruxer versus Bruxer. It's like banging China plates into each other. So, I think, I may have to look into that nano ceramic Kevlar bar wrap, because it kind of sounds like it's got the best qualities of both systems, and really offers another option that provides you flexibility in the end.
Well, I got to tell you, I was at the AO meeting and had a meeting with one of our suppliers, and we've seen kind of what the next generation of the nano ceramic was, and I got to tell you, it looked better than zirconia. I was like, I would have that in my mouth any day. Like, it was absolutely beautiful. And I think we're going to see a trend where, clinicians are probably going to be moving away from definitely acrylic And then even some clinicians, that we work with are moving away from zirconia in general, and just going with nano ceramics up top and on the bottom. If I could touch on, I wanted just to quickly talk about the business model around this. You kind of mentioned that, well, fixed costs and, being able to know how much this is going to cost you, being able to kind of bill out and all that kind of stuff.
Yeah, that's huge.
So, if you look at the conventional workflow, where, you got 15 to 17 hours, if you think about it, you got to be charging $35,000, right? Because there's a lot of work that goes into it.
Yep.
And most clinicians have, sort of an idea of what they like to bill out per hour chair time. On for example, most GP offices are on average around that $500 an hour chair time, and a lot of specialty practices are about $1,000 per hour chair time because they just have higher overheads, right? But if you really think about what is your fixed cost on something like this while covering your chair time? So, for example, if you can do this entire workflow, right, in 4 hours, let's just say that you're going to bill out, $500 an hour, which is your break even, right? So if you look at your fixed costs, you got $2,000 for chair time, and at $500 an hour on average, you're actually making a profit, right? Everything's covered. So you've got $2,000 chair time. Now let's say you got implant components, right? So let's just say that you're using a great value brand, and you get all your parts and pieces for $1,000. So now your fixed costs are at $3,000, right? Now you've got this complete chrome package, right? Which is going to give you this great workflow, and your final restoration at $6,000. So if you really think about it, you're all in at $9,000. So now all of a sudden, if you think about it, if you're at $1,000 an hour at $9,000 all in, at $15,000, you've basically just taken your chair time from $500 an hour to what is that? An extra 6,000 divided by 4. I'll give you a number here. So 6,000 divided by 4. So at $15,000, you're billing out $1,500 an hour. So the point I'm trying to make here is that, with technology, you can actually be a lot more profitable and provide a great service and be profitable in your clinic and not having to charge $35,000 to $40,000 an arch.
Yeah, and it just makes sense, right? The less times you have to go in and mess with something and change parts and irritate the tissue and all of that. I mean, the less times you have to go in and mess with these, the better it heals, and the better the outcome. So it just makes sense to go straight to the end point and minimize everyone's cost, minimize everybody's time, appointments, and failures. I think that's what we're all going for. What's safe, what's predictable, what gets us to the end game better. And it just sounds like this process is finally something that hits all those parameters for people.
Yeah, no, you've really nailed it. And the other neat thing is that I'm going to throw this business model at you that immediate load protocols actually save you money. And
Absolutely.
What I mean by that is, so here's the downside of going delayed load and going to the final. So, for example, you replace the implants, and 6 months down the road, you go to the final restoration. Well, the drawback to that is that you go into the final, but you really haven't had an opportunity to test the implants and see if everything works, right? Because now you're putting the implant under load. So you go to the final restoration, you put the implant under load. If one of them doesn't take, well, now you just spent $6,000 in a lab bill, and now you got to you got to basically suck up a new lab bill, right? Because your implant didn't integrate. Second thing is, and we get a lot of this, is being able to manage patient expectations. Right? You go to the final restoration, you think it's beautiful, you put it in the patient's mouth, and they're like, I don't like it. Well, what do? You've already made the lab bill. You already have the lab bill, so you may have to, redo the case again on your own dollar. Now, the other problem going to the final is like, if you got somebody that has a collapsed bite and they really haven't had a bite for 10 or 15 years, you'll notice that when we temporize them, over time, that bite's going to change. And during that temporization healing phase, you can work out all the bugs. You can control, the occlusion, make any changes that you need to. At the same time, test the implants and also manage patient expectations. And because now you have this temporary bridge, now the next thing is the patient has a backup. If you go to the final and something happens, that patient is never going to be without teeth.
Yeah, and that's exactly true. You need time to develop where the bite is and where the teeth are, and those temporaries allow you to do that while you're figuring out the phonetics and the aesthetics at the same time. So you're testing and finishing the product while it's healing, and that way, when you go to the finished product, you know where it should be, and you know what it's going to look like, and everybody's got the expectations set by then. And you're not having the headaches of the remakes and the part failures. You've already worked through all that as the healing occurs.
Yeah, that's exactly it. And I just wanted to touch on one more thing is how this is like really patient driven is this is something that I think happens a lot. But we had a patient here a little while ago. We treated a lady, and it was with her clinician. She's been going there for 20 years, right? And we actually ended up, they have some kind of a congenital situation where, the teeth are coming out. And anyway, so we ended up doing a delayed load on this lady. Then a few months afterwards, I ended up working with another clinician that was about 3 hours away from this other clinician I just mentioned that we did this delayed load. And next thing you know, I see, and I'm like, I look at the name, and I'm like, I know that name. Well, it turns out it was this lady's daughter, right? And I'm like, well, what are you doing here? I know your regular clinician is in this location, and why are you 3 hours away? Why are you going to get down here? And she says, you know what? I'm 30 years old, and I've seen what my mom had to go through. I'm 30 years old, and I'm too young to be in a denture. So she went to the internet. She found somebody that could provide her the service, and ended up at that clinician's office. And this is kind of like, everybody's kind of, Clear Choice doesn't really have a great reputation because a lot of clinicians think that they're stealing their patients. But I'll tell you, Clear Choice is probably the best thing that ever happened for full mouth reconstruction because they do a lot of advertising and they do a lot of marketing and they educate the patient. And typically this is what happens, right? The patient will get educated by Clear Choice, but they don't go to Clear Choice right away. The first thing they do is they'll go to their existing clinician's office and say, hey, I want to have this done. And when their clinician tells them, I don't do this, or I'm not comfortable doing this, that's when they pick up the phone and they go to the nearest Clear Choice center. So it's a good thing, and the thing is if you're not going to offer the treatment plan, then the patient's going to go somewhere else.
Yeah, and I think the things keeping doctors out of offering this is, comfort with the workflow. And I think what you guys have created is a way to ease the comfort with this workflow and make it safe and predictable to say, look, we can do this in a predictable manner and we can get you there. You just got to take our workflow and do what we do, help you with that. Now, you guys offer some training with this too. Like you'll actually come out and help people with their first case. Is that right?
Yeah, and I think I'm going to be there with you. What we do is that, anybody that's doing their first case, we recommend that somebody from our team will actually fly out that has surgical knowledge and the knowledge of the actual system to basically just make sure that your surgery goes smooth from start to finish. So we offer chairside assistance. We've got a really highly trained team that we fly all over North America. And then the next level is that if a clinician actually wants to do live surgery, we have a training center in Puebla, Mexico. We've got our own hotel there, our own restaurant, a beautiful facility, state of the art. We have clinicians on staff, but you can actually go out there and you can perform 2 full mouth reconstructions on live patients. And as soon as you get off the airplane, we pick you up. We take care of everything, food, everything from start to finish. So it's really a turnkey situation. And what some of the clinicians do, we just had a clinician that just came out. And one of the things that we offer is that you can actually bring your own patients. And I just got back last week from Mexico, and we had a clinician that brought 3 arches with him. And we brought the patients, flew in. We put the patients up in a beautiful part of historic Puebla, Mexico, by the Mayan ruins. They get to do some sightseeing, and then we pick them up. And bring them over to the facility. And they get their full mouth reconstruction, and then they fly back to the U.S. But what ends up happening with this clinician is, he cut the patients a little bit of a deal, right? Because he told them what the situation was. They get a great trip out of it, and he basically paid for all his training and then some.
Excellent. So the patients get a deal, the doctor gets training, and you guys get to get them comfortable with your system, and then they get back to their own clinic, and it's just off and running.
Yeah, that's exactly it. And so it's a great service. So if anybody's looking for live surgical training, where either we'll provide the patients to you, or if you want to bring one of your own patients out and they can have a little vacation and enjoy the sights, and at the same time, get a full mouth reconstructions. We offer that.
So this is a little different. It's dental vacation, but you get to bring your own doctor with you, as opposed to just one you'll never see again.
Yeah, well, you get to bring your own patient, right? Yeah, and hey, if you don't have a patient and you don't want to do it on yours, then we'll provide you 2 patients while you do full mouth reconstruction. Now, how this whole system works is that, if you wanted to get involved in the live surgical training, as soon as you sign up for the course, we're already going to assign you a patient, and you're actually going to begin the CBCT-based treatment plan right away. So it's kind of a really neat concept where, typically you sign up on a course and you don't really start doing stuff until you actually show up. With our system here is we actually start the treatment planning right away. So you're going to be actually issued a couple of patients, and you're going to work with our biomedical engineers, and we're going to take you through the whole treatment planning process from start to finish, and you're going to approve your own plan. And you're going to approve, the stackable device. And one of our instructors is going to be with you, and they're going to look over your plan and just make sure that, everything's the way it should be.
Excellent, excellent. So this sounds all like a really fantastic product. You guys work with almost all major implant companies that have guided systems. You will fly out and work with the doctor on their first case. You have CE, hands-on live patient training. I can't think of something that you guys aren't offering with this package that could trip somebody up on this. So what's the best way for people to get going with this? Just to get online and get a case scheduled and start?
The best way is just to call me on my cell phone. And my cell phone, so my name is Daniel, and my cell phone is 760-898-0858. Or you can email me at daniel@roedentallab.com. And we'll make this very easy for you. What I like to do is when clinicians are doing their first cases, we really make sure that everybody has a great experience, and we'll walk you through it one step at a time. It's not going to be a situation where somebody throws you a 20-page manual and says, figure it out. We've got the technology where, as soon as you get the records, I can log into your computer and, like I mentioned, create this upload portal for you. I can work with your staff to make sure we get the proper records and really take you through it a few times until you're comfortable doing it on your own.
Yeah, and I'm going to provide links and opportunities for people to do that you guys are setting up. So I will provide people the information they need to get a hold of you and to take some of these courses. So I'm really looking forward to getting this case going. I know we're got one planned in April. I'm super excited about that and to partner with you guys. I love what you're doing. I think it's fantastic, and I have no doubt that you guys are, by far and away the leader in this industry. So I'm really excited about this opportunity, and really appreciate everything you guys are putting together for implant dentistry. It's changing lives.
Yeah, you're 100% right. And what I would like to add is that, if anybody wants to get a little bit more information on this, please just don't go to the website. If you can contact me, I can do a 20, 30 minute web meeting with you, with whatever clinician wants to learn a little bit more. And we can actually go through the whole entire thing, and I can show some clinical cases and answer any questions that you may have. So we offer that service. Just please just contact me, phone me, text me, email me, and I could set up a web meeting at your convenience and really take you through this system from start to finish. Now, so we just kind of covered Chrome here. But we have a couple other stackable systems that are really neat. One we have that we're launching right now, it's called the Speed Bridge. But basically what it is, it's a protocol that's halfway in between kind of what the modality is for a full mouth reconstruction. What I like to call it, it's as closest to a Ferrari you can get on a budget. But the protocol is priced to the patient around $16,000. So it's not, so say for example, an immediate load fixed is about $30,000. then, really, if you look at the marketplace, there's really nothing in between. So either you're spending $30,000 or you're getting some implants and you're getting a locator denture, 6 months down the road, right? Now, for some patients, that's a deal breaker. I can't be an immediate denture. I have to function. I have to talk. I'm just going to hang on to my crappy teeth, doc. So what the Speed Bridge is, it's a solution that to the patient is priced around $16,000, but it's still a stackable system. But instead of going to a fixed prosthetic, we actually go to the final bar and a removable denture over top. And this is done in one appointment. So what you basically in essence have is you have the stack that's built, but then instead of, putting this prosthetic carrier and lining up the prosthetic like we do in our conventional workflow, we're actually installing the final bar. So we install the final bar, and then we have a removable bar retained overdenture that the patient can clip in and out during the healing phase. And the reason why we can load this is because we're cross-arch stabilizing the implants by splitting them together in a bar. But and then the patient has basically a removable prosthetic. Now, we're still trying to work out the pricing on this, but the price is going to be around $3,500, and that's going to include your entire stack. It's going to include your final bar. It's going to include all your treatment planning. It's going to include your temporary denture, and it's going to include your final denture.
Oh yeah, that's fantastic because in my office, patient comes in and they've got terminal teeth, and I say, look, I can give you a denture, which is terrible. We're not going to talk about that. I can give you kind of an overdenture, which is kind of your step above, or we can go to the top shelf and do fixed full arch, right? And so you've got solutions for both of those now. You say, look, we can do that medium option for you too, and we kind of do it the same way. We stack it, we make it guided, we make it predictable, same day, but it's just a different system at a different price point at a different package. And that's I don't know anybody else who's got something like that on the market either. So that's another option for people and doctors that to give two price points.
If you really think about it, the protocol on the Speed Bridge I just mentioned, let's just say after your fixed cost, it's a procedure that basically takes about an hour and a half, and for an hour and a half, you're billing out about $12,500.
Yeah, and you're giving somebody that's so much better than just a basic 2 or 4 overdenture. It's something that really is a good service.
Yeah, and the advantage is, if you really think about it, right? If you're dealing with locators, the patient still has something that's tissue borne. So they still may have sore spots. They still can't eat stuff with seeds on them, and you're probably going to have bone loss around those implants because they're not splinted together. And sometimes we see patients that sometimes the patients will put the denture in over top of the locators and bite into it. And sometimes what happens is they prematurely wear out the locators. And we've had patients who are coming in and you got to replace those locators every 6 months, and they're like, well, doc, you didn't tell me that I'm going to have a $700 bill every 6 months, right? And that can cause issues. So when you get into a system where you're actually splinting the implants together, you're going to have better bone maintenance. Now the patient's going to have higher chewing capacity because now they have a prosthetic that's bar retained. And again, now everything rests on the bar and not on tissue. So and because we're milling all of this stuff into the bar, what ends up happening is we can be very parallel with the connectors on the bar, whether it's O-rings or locators or whatnot. So you're going to have a perfect path or draw, and that's going to decrease any premature wearing of the retentive components. Yeah,
it's just another genius system that solves a problem that doctors and patients don't have. And I think that's what the beauty about these is. It's solving problems that patients and doctors face every day in a predictable and safe manner.
Yeah, that's exactly it. And then that brings us to our third solution where for example, we have a stackable system, which is more kind of like a conventional crown and bridge, where very minimal bone reduction, if no bone reduction, but we create the stack and the prosthetic that goes over top. The pontics almost fit inside the extraction sockets, and it's basically like a fully guided stackable system, but with the end result being more of a crown and bridge style for a full arch.
Fascinating.
Yeah. So again, if anybody would like to learn a little bit more about some of the custom solutions that we have, please just contact me. We can do a quick web meeting. I can take you through all the different solutions that we have. We can discuss your case and figure a way to make it easy for you to move forward.
Yeah. I can honestly say I've never met somebody who's more accessible than you. I'm not sure when you sleep or eat or take a break, but I've called and texted you at various hours. I'm on one side, you're on the other side of the coast, and you're coming and going from Mexico and all over the country. And I swear you're by far the most accessible person I've ever run into. I'm not sure how you do it, but I know.
Well, I work on 3 different time zones, and here's the thing, some people get up and go to work, and some people get up and they really love their job, and that really makes it so much easier. Having the opportunity to speak with top-notch clinicians like yourself, from over North America, and helping them help patients, and make this affordable for patients, and make it safe and predictable. It's a great feeling. And what's happening right now is there's going to be more GPs placing implants by 2020 than there is going to be oral surgeons. And that's a trend that's happening. And, one of the things about, trying to treat these patients in your practice is, if you have these procedures that are unpredictable and you've got to go, it's got to be a 6, 7, 8-hour procedure, which sometimes, these cases go that far. It's just not safe and predictable for anybody. As sometimes these patients will metabolize the freezing, and then, there's only so many carpules you can give them before it gets dangerous, but you're only halfway through your protocol. And I've been in those situations. It's just not a great feeling for anybody. And the great thing about this system is that, you can do this with some training in your office under local anesthetics and be in and out in under 2.5 hours.
Yeah, and that's the thing. Not everybody wants to be sedated, or you've got people that can't be in the chair for 6 hours, and by God, who wants to be in a chair being operated on all day and having stuff in and out of your mouth 100 times? I mean, it just there comes a point. It's like, well, when is enough? Like, and I think we finally found a system that reduces all the negativity there and says, let's just get down to it. Let's get in. Let's get done what we need to. Let's get it simple and make it easy and affordable. And I just love the fact that you guys have found a resource for all those.
Yeah, I'm with you 100%.
Well, I'll tell you what, I think we've covered all the aspects that we can do for one good podcast. Daniel, I will post this in the near future. I'll have all your information, all the information for the Chrome package, and a little something special for our listeners that you and I are working on. So I will have people get in touch with you. They can reach out to myself, and we'll provide all the contact info. I look forward to seeing you and getting our cases going. I've got a lot of people I've been waiting to just get your system going, and really looking forward to getting this relationship started. So I really appreciate your time today.
Well, thank you. I really appreciate your time as well, too, and it was a pleasure. And I'm hoping when we get something new out, I can come on again.
Absolutely. We'll do a follow-up for sure, I think, in the near future.
Yeah, it would be great. So what we could do is maybe on the next one, we could maybe get Ike involved. I know he wanted to come back on your podcast, and then we can kind of get kind of more of a roundtable discussion from more of a clinical aspect of it in regards to kind of how all this works and some other stuff that I think your listeners will find very interesting.
Yeah, I think today's a good surface view. We'll dive in deeper. I'll get my first one under my belt with you. Then we'll dive into the technicalities about all the details and really dive in deep. So we'll set something up for that for sure, and look forward to getting that going.
Okay. Well, hey, thank you so much for your time. Looking forward to talking with you again.
All right. Thank you, sir.